Okay, why don't we go ahead and get started so you guys can get your afternoon underway. Hello, everybody. So today we're going to talk about altitude illness. Tomorrow we're going to do sea creatures and envenomation. And then Friday we're going to do backcountry orthopedics. We're going to get a little stretcher table up here and we can do some demonstration. You guys can try some hands-on stuff if you want. It's reducing common dislocations and how to examine for certain fractures and stuff like that. So we'll do that on Friday, tomorrow sea creatures, and today we'll do a little bit altitude illness here. Has anybody traveled and done any travel above, let's say, 8,000 feet? That'd be like 3,000 meters. So somebody in the back. Pardon? Yeah, so Denver's at 5,000 feet. If you go up to any of the ski resorts, you're at least at probably 8,000. And if you go to some more, you're at 10 or 12,000. So traveling and visiting areas like that, you're at risk to develop acute mountain sickness and some of the other altitude-related illnesses. They can be prevented. We're going to talk first we'll talk about what they are, what differentiates acute mountain sickness, high-altitude cerebral edema, high-altitude pulmonary edema. So those three. And then we'll talk about what you can do to assist with acclimatization to prevent those. So we'll do a little bit of physiology here. Again, kidneys are important because they help regulate some of your respiratory response by creating a metabolic acidosis. So it drives you to create a respiratory alkalosis, which makes you breathe faster. And at altitude, because of falling oxygen levels, or falling oxygen pressure is a better way of putting it, by breathing faster, you can maintain your blood oxygen level. So we're going to talk a little bit about that stuff today. This is, again, designed to be like maybe an hour and a half, 2 hours. We're going to fly through some of this stuff. We'll try and finish it in an hour. There'll be some stuff that I'll just kind of skip over because maybe it's a little redundant, because I'd like to get to the end of it and be able to do this in about an hour. And again, just flag me down if you have any questions. So first of all, for those of you that have not traveled to the great north, that white stuff is snow. This is what Lynn and I will probably be going home to. Maybe not this much, but we'll be going home to snow in relatively short order. This is somewhere out west, maybe Montana. Okay, so what is altitude illness? We talked about the three syndromes. Acute mountain sickness, which is very common. High altitude cerebral edema, which is going to give you neurologic findings at altitude, and high altitude pulmonary edema, which is going to give you respiratory symptomatology. You can have overlap of 1, 2, or 3 of these. You can have, it would be unusual to have HACE or HAPE without having acute mountain sickness. Usually you get that at lower altitudes. They can overlap, but important to separate things that are affecting your lung and things that are affecting your brain. Oh, I got this little thing. There's other things that you can get also at altitude, unrelated to HACE, HAPE, and acute mountain sickness. Certainly retinopathy, retinal hemorrhages. I don't know if anybody's ever seen that. I think it's on Netflix. It's called Meru, M-E-R-U. It's about a team that treks up to high altitude in the Himalayas, and it talks about, and a lot of these symptomatology occur there. So if you're ever looking on your vacation, you have some downtime, it's a really interesting flick. Periodic breathing, it's called Cheyne-Stokes breathing, where you will breathe faster and then you'll breathe slower, faster and slower. We see it in diabetic ketoacidosis. We see it in other medical conditions. Altitude can mimic that. Dry eye, which is extremely common because the higher you go in altitude, lower humidity, tend to dry your eyes out. That would be something I would tell you if you're going to be traveling to high altitude, take some lubricating eye drops, something like Sustain or something like that. Visine is not a lubricating eye drop. Visine constricts blood vessels. You want something that's a lubricating drop, and you can also take mineral oil or omega fish oil, that kind of thing will help with dry eye at altitude. It's normal to develop a cough at high altitude too. Again, just because of the dryness at altitude, your lungs dry out a little bit, you can develop an irritative cough. And then if you have underlying pre-existing conditions like cardiac disease, hypertension, you're likely to have some exacerbation of those conditions. We're not going to focus too much on these. We'll focus on the other big three, but these are some things that you can see. Okay, so what causes high altitude illness? Hypoxia. What's the normal oxygen concentration in normal air? 21%, so 0.21. The rest is mostly nitrogen and then other inert gases, CO2, et cetera, but oxygen, 21% at sea level. So your barometric pressure, oxygen is 0.21. As you go up at 3,000 meters or 900 feet above sea level, it's about 2/3 of that. At 5,500 meters, it drops to about half of that. And then at Mount Everest, it's about 1/3 of that. For those of you that have seen any of these kind of Everest trekking movies, et cetera, anything above 24,000 feet is the death zone. If you are not properly acclimatized to that altitude, you're not going to last too long. So here's a question for you. What is the oxygen percent at 5,500 meters? Remember we said it was half at 5,500 meters if it's 21% at sea level. 10.5. So he took 21 and divided it by 2. The answer is 21%. There's always 21% oxygen in the atmosphere as you go up. It's just that the barometric pressure decreases as you go up. There's less. Think of the atmosphere as pushing down on you at sea level. You're at 1 atmosphere, 21% oxygen. I go up 5,000 feet. It's still 21%, but there's less of a pressure. So the pressure gradient is less than it is at sea level. And that's why the number of molecules of oxygen is less, but it's always 21%. It's a good trick question. He fell for it. No surprise. So you can see along the bottom is barometric pressure. 760 is sea level. As you go up in altitude, your barometric pressure is going to drop. Again, remember the blue, the schematic on the right, red signifies oxygen, blue is nitrogen. So the concentration is always the same. As the barometric pressure falls, the percentage stays the same, but the actual absolute amount of oxygen goes down. Make sense? Here's some examples of where that might be. Denver, Colorado at about 5,000 feet. You can see that barometric pressure drops from 760 down into probably mid 600s. When you're on a commercial aircraft cabin, even though it's pressurized, it's the equivalent of being at 8,000 feet altitude. A pressurized commercial airline is the same as 8,000 feet. You can deal with it if you're only up there for, I don't know, 4, 6, 8 hours, but for extended flights, for your patients, let's say you have somebody who has COPD or other respiratory conditions, pulmonary hypertension, and they're going to be taking a long flight, a 12-hour flight from the United States to Australia or what have you. That's significant. That's a significant pressure on their system, stress on their system. Linda and I take a group of very sick people to Lourdes, France on a spiritual pilgrimage every May, and many of the people don't require supplemental oxygen at sea level, but we go up in a commercial airline mimicking 8,000 feet. They require oxygen therapy. So just be mindful of that. If you have friends, family, relatives, patients who are brittle with their respiratory status, going to be traveling in, it's the same as 8,000 feet. We mentioned ski resorts, typically above that. Mount Everest, you can see you're way up there. The oxygen concentration remains at 21%, but the absolute oxygen in the air is much, much less than that. Again, some schematics here. I was talking, or is he talking with Henderson before? That's why people will train if they're going to Mexico City to play in a football match or a soccer match. They'll train at altitude because they're at nearly 7,500 feet. That's going to be a significant. I think La Paz is maybe the highest capital. I think La Paz is the highest international capital as far as altitude is concerned. And again, you can see Mount Everest just kind of dwarfs the rest of these areas. So there's another situation that's occurring in addition to altitude affecting the amount of oxygen available. As you breathe in oxygen, right, you take it into your lungs, the pressure of the oxygen is going to decrease as it goes from atmospheric air to your alveoli, into your arterial blood, into the tissue capillaries, and into the mitochondria. That pressure is going to fall. So let's say we said it's 760 millimeters of mercury at sea level, 21% of that. As you go down, it's going to drop and drop and drop as you go further down this cascade to get to the cellular level. So here's a little bit of a schematic on that. Again, at sea level, your atmospheric pressure is 760, 21% gives you a pressure of oxygen of 159 millimeters of mercury. You can see that here, right? That's the starting point of oxygen cascade. So everything else being equal, 159 millimeters of mercury. That's the starting point. As the oxygen moves down to get to the cellular level, it can drop as low as 5 millimeters of mercury at the cellular level. That's why if you're impacting this 159 as you go higher and higher at altitude, by the time it gets to the cell level, it's going to be significantly less than the 5 millimeters of mercury there. And that's why you go into an anaerobic state. The cells, the mitochondria, are not getting the oxygen they need. That's why supplemental oxygen can be very, very beneficial when you're at altitude. Understand? Okay, so why do some people get acute altitude sickness and others don't? First of all, just like we said the other day with heat exposure, acclimatization is very important. How many days did it take to acclimatize to heat? 10 to 14. So let's just say, just shy of 2 weeks. There's a couple of different acclimatizations going on at altitude. But if you go too high, too fast, when it comes to altitude, you're likely going to develop one of these syndromes. So altitude illness is determined by the absolute altitude reached and how quickly you go up. Genetic factors play an important role in this and your individual physiology. And then age, gender, fitness, actually not that much of effect. You can have people that I've seen cases where people are very fit, they're physically fit, they exercise, they're fitness instructors, et cetera, et cetera. They go to altitude and they get sick. And then somebody else who maybe doesn't exercise goes there and they don't have much symptoms at all. Maybe they both acclimatized about the same, but so fitness doesn't particularly protect you from this. Not to say that being fit isn't a good thing, but it's not going to necessarily protect you. Genetic factors play a big part in this. Age, you would think, again, I always say the extremes of age, the young and the old are more susceptible to these things. Probably still stands true here, but it's not as much of a factor as you would think. And gender, no impact. So acclimatization, there's a couple things going on here. Time makes a difference in this. The ventilatory response is kind of your first phase of acclimatization. Your kidneys are important in acclimatization as well, and we'll see why that is. So when you go to altitude, oxygen levels drop. It triggers your respiratory status to increase. So instead of breathing 12 to 20 times a minute, maybe you're breathing 16 to 24 times a minute, in that range, right? So when you're breathing fast, you're taking in oxygen, you're exhaling CO2, right? So if my normal CO2 is supposed to be about 40, if I blow off a lot of CO2, like that case the other day with hyperventilation, it's going to drive my CO2 in my body down, and that creates what's called and it's going to shift the pH. That's what's called a respiratory alkalosis. respiratory alkalosis. So my pH of my blood is going to go up. My CO2 level is going to go down. Does it make sense? You know, it's all acid base. Hydrogen, H2O plus CO2 equals hydrogen plus bicarb. So when you affect any one of those things by blowing off CO2, it's going to affect the pH in your blood. And your body is always trying to compensate to keep the pH of your blood at about 7.4. So the respiratory and the renal system are working hand in hand to try and keep your pH at 7.4. So if you're breathing faster, kidney's going to react. Respiratory compensation happens fast because I can change my breathing pattern pretty quickly. I can start blowing off CO2 right now, and I could change the pH of my blood pretty quickly. We do this in people who have an intracranial hemorrhage. We will sometimes hyperventilate them to change the pH, cause some vasoconstriction, will lower intracranial pressure. The kidneys that are regulating metabolic acidosis or alkalosis, it takes longer for that. So there's a little bit of a lag. But your body initially, with altitude, is going to cause you to breathe faster. CO2 drops, pH rises, and your oxygen level transiently improves. You can see it right here. So that's respiratory acclimatization. There's also hematologic acclimatization. What is this? This is an increase in the oxygen carrying capacity. This is when people blood dope. They give themselves a little. They take they do an auto transfusion. They'll take a unit of their blood. They'll take it out of their system, and then they'll let their body compensate. They'll take iron or B12 or folate or whatever. Their H&H will go back up to normal, and then they'll self-transfuse their own blood. That's blood doping. That'll give you a hemoglobin of about 15, 16, 17. I think this is what the Lance Armstrong did and got kind of nailed for that. That'll increase your red blood cells and hemoglobin in days to weeks. If you do that naturally, this will occur at altitude. Your body will kick up the generation of red blood cells by releasing erythropoietin, and it'll cause your bone marrow to produce more red blood cells. So when you see people that are chronically living at altitude, the Sherpas in Nepal, they probably have hemoglobins of about 17. As you come down, your body compensates and they'll destroy some of those new cells. It's called neocytolysis, and stress of altitude will cause erythropoietin to make more cells. One of the things that's important with this, that's why it's important to keep yourself really, really hydrated. For patients that have elevated platelets, elevated red blood cells, they're more, just imagine the viscosity of their blood is higher, more prone to have blood clotting, sluggish blood flow. This is why you can have a thrombotic clot at altitude if you're a little bit dehydrated and your blood platelets or your blood red cells are elevated. So we talked about ventilatory acclimatization. That happens pretty quick. That can prevent the acute mountain sickness to a degree if you properly acclimatize. So there's a medication, Diamox, carbonic anhydrase inhibitor, that's going to create a metabolic acidosis, and it's going to trigger you to breathe faster. So it mimics altitude. And we'll talk a little bit about how you take this and to acclimatize yourself. But this would be one of those things that if you were going to be traveling to altitude, let's say you were going to Machu Picchu, or you were going to be spending time in the Sacred Valley or in Cusco at altitude, 12,000 feet, you'd want to have some Diamox and take it a day or two before you go. Take it a day or two while you're there, and then you can stop it because you've properly acclimatized. So it also increases brain blood flow and helps prevent acute mountain sickness and cerebral edema. Is it more severe the higher you go and the faster you go? Yes and yes. So you need to take your time going up, and that's why when you go on these trekking trips, they usually map out the amount of altitude change that you do in any 24-hour period of time. The ideal thing is to climb higher and then sleep lower. climb higher, sleep lower, so that your body's acclimatizing, and then you come down and you sleep at a lower altitude. I think we have a schematic of what a trek to Mount Kilimanjaro might look like. The faster you go up, the more problems you're going to have. Usually it's going to occur in the first 3 days. Talk about the symptoms, physical findings, differential diagnosis. It's a lot like a hangover. I'm sure none of you in this room have ever had a hangover. But if you have, then you're very familiar with this. Headache, anorexia, nausea, vomiting, dizziness, uncomfortable, but I just can't sleep. You may get some pooling, peripheral edema. Usually this is going to be several hours after you get to altitude. So clinically, the definition is headache plus one of these additional symptoms. Remember, not all headaches at altitude are going to be caused by acute mountain sickness. Somebody has a sudden headache, worst headache of their life, you got to think of other causes of that, subarachnoid hemorrhage, other causes. But if they have headache, nausea, vomiting, and it kind of fits with the clinical scenario of rapid ascent with improper acclimatization, that's gonna likely be the diagnosis. So when you go, if you're going on a trip and you go up to 8,000 feet, first thing you should do when you get there is drink lots and lots of fluids, lots and lots of fluids. You should avoid alcohol in the first 24 hours of any kind of altitude, and don't eat that much, because when you eat, blood gets diverted to your digestive tract and it can make things worse. So if you go into any kind of altitude, keep yourself well hydrated, stay away from the booze for the first day or so, and I'd stay light on the diet, particularly if you're going to if you do get sick and you're going to have a little anorexia or nausea, vomiting, better to just have a little bit of an empty stomach. That's what you look like with acute mountain sickness. You feel like shit. You got a headache, feel like you're going to throw up, you're very weak, similar to a migraine or a hangover. Okay, so now we'll shift gears. Cerebral edema is something different. That's a lot more serious. That's actually brain swelling, expansion of the brain within a closed space. This acute mountain sickness can progress to cerebral edema, and someone with acute mountain sickness, or as we said, you can get overlap with pulmonary edema. It's not going to happen below 9,000 feet. This is usually when you're up at 9,000, 10,000 feet. Ataxia and altered consciousness, acting drunk, losing, your gait is disturbed. They go to stand up and they're falling backwards there. Confusion, repetitive questioning, almost like you've had a concussion. That's what cerebral edema will do to you. These are the percentage of what will happen. You can actually lose consciousness. Ataxia is pretty common. Altered consciousness, papilledema, swelling of the retina, which is a sign of cerebral edema. Don't lose the art of the physical exam, by the way. As we become more technological, we rely on CAT scans and MRIs and imaging. Be a good diagnostician. Physical diagnosis is still something very important, because no matter what clinical setting you're in, there's always a possibility that you may not have some of these tools at your disposal. So be good at doing a physical examination. Abnormal plantar reflexes, you get that because of calcium dysregulation and magnesium dysregulation. Seizures in 2% of patients with HACE. I don't really know exactly why this happened. It's probably due to vasoconstriction, impaired cerebral blood flow, vasogenic edema. That means it's caused by vascular changes. You may have some cytotoxic cell death edema, inflammatory, oxidative stress. They don't really know why it happens exactly. So again, a little schematic. Greater than 2,000 feet, acute mountain sickness. Over 3,000, potential cerebral edema. As you get above 4,500 meters, you're looking at pulmonary edema as a possibility. The symptoms we talked about: encephalopathy, ataxic gait, disequilibrium. Lassitude is just fatigue, mental function decline, altered consciousness. If you're with someone and you're the medical person on a trip and somebody's starting to act a little bit goofy and you're above 9,000 feet, they're only going to get worse if they keep going up. So you need to pause, either give them supplemental oxygen and or go down in height. Descent is the definitive treatment. Dexamethasone, Decadron, is the rescue treatment. We'll talk a little bit about dosing on that. So if you're going to go to altitude, that Decadron or Dexamethasone, either oral or injection, is something you want to have in your medical bag. And we talked about the Diamox. You'd want to have that in your medical bag as well. There are some of these hyperbaric chambers that you will see at base camp at some of these on these treks in Nepal. They'll have hyperbaric oxygen tanks, which is basically like an inflatable sled that they will inflate with compressed oxygen, and they'll simulate 1 or 2 atmospheres of oxygen to try and normalize it. So we've seen a couple of x-rays last week and this week. So remember, the cardiac silhouette sits in the middle. Your right is the patient's left. Your left is the patient's right. Remember, the heart kind of sits in the left side of the chest for the most part. I know you're not going to be able to see this little red thing there real well. That's the aortic knob. Aortic knob. You can see some air in the trachea coming down. That'll be the carina somewhere right there. You can see the left main stem bronchus there. This is the cardiac silhouette on both sides. These are the diaphragms, right? These are probably some extra clothing straps. All of this fluffy white densities on both sides of the chest is abnormal. That could be consistent with pulmonary edema. It could be consistent with acute adult respiratory distress syndrome. Basically, it's fluid in the interstitial space. So this would be the x-ray you would see with somebody with acute pulmonary edema secondary to high altitude. In a patient with chronic congestive heart failure, an elderly person with hypertensive congestive heart failure, they're going to tend to have a little bit of a bigger heart than this. That's why this looks like acute pulmonary edema versus somebody with chronic congestive heart failure. Chronic congestive heart failure, you're probably going to have cardiac silhouette enlargement. Remember, normal is less than half of the diameter of the chest. The cardiac silhouette itself doesn't look that big, but all this white, fluffy densities on the left and right side of the chest is not normal. There's things you can see, pulmonary vascular congestion, curly B lines, which are out at the periphery. There's a lot of stuff they're doing now with bedside ultrasound, where you can put a bedside ultrasound on the chest and you can actually see findings that will be consistent with interstitial fluid. I'm sure you guys will get some exposure to that in your 3rd and 4th year. So pulmonary edema, that's the schematic of that. Early symptoms are going to be fatigue, weakness, dyspnea on exertion, DOE. That's typically something that you would ask someone if you were evaluating them for signs of symptoms of pulmonary edema. Do you have shortness of breath on exertion? Do you have dyspnea on exertion? You often ask them how far they can walk before they develop shortness of breath. Can you go up a flight of stairs? Can you walk, down the hallway? There's something we do in the hospital to assess improvement. We do like a 60-second trial of walking. How far can you go in 60 seconds? How many times can you go back and forth down the hallway in 60 seconds? If that's improving with treatment, then you know you're making a positive impact. Typically going to have some abnormal vital signs, tachypnea, tachycardia. Orthopnea, what is orthopnea? When you lie flat at night, you increase the pulmonary pressure, the intravascular pulmonary pressure in the chest. So some people might have 2-pillow orthopnea. They have to sleep on 2 pillows at night or 3 pillows. So orthopnea is being able to sleep flat, or the absence of being able to sleep flat. Blood-tinged pink or blood-tinged sputum, frothy sputum is common with pulmonary edema, whether it be congestive heart failure and/or high-altitude pulmonary edema. Rails sound like crunching of like Rice Krispies. So when somebody takes a deep breath, you hear this little like crackling sound at the bases of the lungs. That's congestive heart failure, or that's fluid in the interstitial space. In high-altitude pulmonary edema, that tends to start on the right side. Again, don't forget the importance of a good physical examination. If you're a medical person on an expedition, or you're accompanying a group on a trek and you have a stethoscope with you, you need to listen to their lungs. Are they totally clear, or do they have rales? Somebody who has totally clear lungs that's short of breath, maybe just got off a long plane flight, maybe you think more of a pulmonary emboli, right? Clear lung sounds, shortness of breath, think of PE. Somebody who's got shortness of breath at altitude or not at altitude, you listen and you hear rales, more likely congestive heart failure. With a fever, consider pneumonia. Pneumonia can give you rales also, but it can give you other adventitious breath sounds. So at altitude, sometimes they have these medical tents, listening to the lungs. This is the pulse oximetry. That 97 represents their oxygen level. That's pretty good. 57 is their heart rate. That's pretty normal. Again, if you're the medical person on an expedition, you would carry a little pocket pulse oximeter. You can buy these things on Amazon and pretty cheap. So how do you prevent this? Because it's one thing to treat it. It's another thing to prevent it. To get mild acute mountain sickness, headache, and a little nausea, sometimes it's just going to happen. Even if you do everything right, it can still happen. But again, you can mitigate it with fluids, acclimatization, don't drink booze, don't eat a whole lot, take your time going up. Pretty manageable. Doesn't really affect your functional capacity. If you can prevent acute mountain sickness and HAPE, you probably won't get the cerebral edema. In today's day and age, if you can identify it, nobody should die of this. So who's more at risk? If you sleep at a higher altitude, so let's say you ascend and you get to 10,000 feet, it's your first day, you high climb, you sleep there, you're probably going to have a problem. So again, they say ascend, hike high, sleep lower. So if you go up and then you come back down a little bit or you descend, that's why a lot of these people that are going on these big expeditions, they'll do a day hike, they'll get up and they'll come back down to base camp and sleep. So they're kind of acclimatizing themselves to that altitude and then they're coming back down to sleep. There's certain ski mountains out west where if the place you're staying and sleeping is at 8,000 feet, you may be fine. If you stay up at another resort that's at 8,500, 8,700 feet, you may have those symptoms. So just that little bit can make a difference. You can pre-acclimatize, and I think we have some schematics of that. And again, that individual susceptibility is a big piece here. Climb high, sleep low. About a 1,000 to 3,000 foot difference is recommended. So you would want to ascend about 1,000 feet higher than where you sleep. Stay hydrated, 2 to 4 liters. Remember, your respiratory rate is going to be faster. So you're going to be blowing off not only CO2, you're blowing off water. Tend to get dehydrated. So your fluid demands are going to be higher. You can get these kind of things. You can actually, this is pretty cool. It's a altitude tent sleeping. So let's say you were going to spend, I don't know, lots of money to go on one of these trekking trips to Nepal, right? You don't want it to get ruined by getting sick and not being able to complete your journey. So people can actually get these things. You can buy these things or you can actually rent them. So here you can rent this tent for about $600 or $700 for a month. So you can pre-acclimatize yourself. Athletes do this if they're going to be competing at altitude. I think there's another, I won't show you the full, well, actually I will. See, I don't even know where I got a Mile High training. You can get a tent package. It gives you a bunch of different stuff here. All different kinds. And that's going to acclimatize you to high altitude. Oh, that's just a different one with a mask. You can also get training bikes where this can simulate hypoxia, or it can simulate a lower oxygen pressure. So you can actually be exercising while at a lower altitude. Again, this would be good if you were training and you're going to be doing some high altitude physical activity. Again, these, you can purchase these or you can rent these. Here's an example of a trekking schedule. Again, this is for, where was this? Kilimanjaro, which I think the peak is somewhere around 5,900 meters. So maybe it's 20,000 feet. But so it's high up there. It's a high altitude. And you can see you're climbing up slowly, you're acclimatizing. You have one day where you go a little higher and then you come back down. Ideally, there should be another day where you go up and then come back down, climb high, sleep low. And then there's no problem as you descend. You can descend relatively rapidly. And that's about a 8-day. So again, these are the things that we'll talk about prophylaxis here. We talked about hydration. People that are low risk, if you've been out west before, you've been to altitude, haven't had a problems, chances are you'll do pretty good. Several days of acclimatization. Repetitive of what we just talked about. Very rapid ascent. That says raped. It should be rapid ascent. I'll have to fix that typo. Anybody know where that is? Anybody know who this is? Sitting right over there. This was in Cusco. Cusco, I think, was around 11 or 12,000 feet. We didn't feel so good when we first got there. So what do? I tried not to drink. I drank a little. And then they had the coca leaf tea. I was down on that stuff. Didn't really help too much. It's a very dilute alkaloid type tea. It's not the same kind of cocaine that you get down in at lower level. But it contains some of the things that will help with that. A lot of the people that work at altitude are always chewing this stuff in their mouth. Gives them energy and helps ward off some of the symptoms. Actually, when you go to Machu Picchu is only about 8,000, 8,500 feet. So you go down. So we went to Cusco first. We spent 2 or 3 days there, acclimatized there, and then we went to Machu Picchu and hiked there, and we didn't have any problems there. That's Machu Picchu. When you hike, there's a bunch of vistas that you can overlook there. This picture was from probably a website or something like that, but this is exactly what it looks like when you're there. It's a beautiful place. Safe ascent. So just kind of in summary, risk assessment. If you're doing a assessment of a team that's going to be doing ascent, you want to take that history. Have you had problems before at altitude? And if so, what were those problems? Little acute mountain sickness. Okay, we can deal with that. Oh, you had high altitude cerebral edema. Okay, let's see what we got in our kit, and let's put a plan together for you. Remember, we said physical fitness is not protective. Good to be fit, but it's not necessarily going to protect you from this. Someone starts to have symptoms, you should probably address those early on. Don't ignore them. Rest, immediate descent. Never leave a sick person alone, because let's say if some mild symptoms, you say, okay, we're going to hike up, you hang here. That's the person who, if they develop any kind of confusion, ataxia, they could have a serious fall, or they could get lost. So some of the meds you would take with you, acetazolamide down here on the bottom right. That's Diamox. Comes in 125 and 250 milligram tablets. I always carry the 125s with me, and then maybe I'll take them for, let's say I'm going out, I'll take them a day before, take them on the plane going somewhere, and then for the first day or two I get there, I'll take the Diamox. I'll have the dexamethasone or the Decadron with me, and I'll only take that if I'm starting to get a little bit of a headache or starting to feel really shitty. Ibuprofen, always good to have, non-steroidal, anti-inflammatory. I like naproxen, which is a leave, is Q12 hours versus every 6 to 8 hours. Ginkgo biloba, no definite evidence. Aminophylline, which we sometimes gives to increase your respiratory rate, doesn't work. Gabapentin, sumatriptan, which we treat migraines with, none of that works for acute mountain sickness. So this would be on one of your travel kits if you were going to be going to altitude. You'd have some dexamethasone tablets, 2 milligram. You'd have some Diamox, and you'd have some ibuprofen. Other things that have been tried that don't really work, antioxidants, aldactone, which is basically a diuretic. It's a potassium-sparing diuretic. Phosphodiesterase inhibitors. We use that for pulmonary hypertension. Sildenafil, relax smooth muscle. Nifedipine, which sometimes we use for pulmonary hypertension. That doesn't necessarily work. Magnesium leukotriene blockers, they've been tried, don't really work. This is the coca leaves, drinking coca tea. Does it help? Well, let's see if it helps. Let's see what this article here talks about, that acute altitude sickness, sacred to the Andean people, traditionally relieve the symptoms of mild altitude sickness, contain alkaloids when extracted chemically, are the source for cocaine. However, the amount of coca alkaloid in raw leaves is small and non-addictive. A cup of coca tea prepared from 1 gram of coca leaves contains approximately 4.2 milligrams of organic coca alkaloids. You're not going to get high or have any of that kind of effect from it, but maybe it'll help with the headache. Sorry, I thought there was a video on that one. And you're really not supposed to leave with that when you leave the country in your plane bag. I accidentally threw some in there. I didn't get caught, but you shouldn't really be doing that probably. So here we talked about the treatment for mild rest, go down in altitude, analgesics. Oh, Zofran or ondansetron is a good thing to have in your bag too. It's a great antiemetic. If you get any kind of food poisoning in your travels, nausea, vomiting, or if you have acute mountain sickness, Zofran or ondansetron is good to have with you. It comes in 2 4 milligram tablets. The ODT will dissolve under your tongue. That's definitely a must to travel with. Again, most of these, whether moderate to severe, you need to descend. Dexamethasone, consider moderate to severe. Low risk, we talked about, no prior history, a couple of days to acclimatize. Moderate if you go up there too fast and you maybe have a history or don't have a history of it, you're much more at risk if you do. Someone who's had HAPE or HACE, you really need to evaluate whether it's safe for them to go to altitude. Diamox, we talked about, it comes in 125 and 250 milligram tablets. Produces a bicarbonate diuresis, a metabolic acidosis, stimulates ventilation, raises your PO2, promotes an ion exchange across the blood-brain barrier, also to prevent the cerebral edema. Some of the side effects of acetazolamide, you can actually get a little myopia. It's considered a mild diuretic, but at those doses, you're not going to have much of a diuresis. If you're breathing too fast, remember we talked about that hyperventilation syndrome, carpal pedal spasm, perioral numbness. You can get a little bit of paresthesias and a metallic taste in the mouth, generally pretty mild and self-limited. You should take the Diamox 2 or 3 days. I usually say 1 or 2 days before I go, 1 day before. The day of the ascent, you take some more, and then you can stop after you're at a stable altitude. Dexamethasone, again, have it in your kit. You may not need to use it. It's an alternative to acetazolamide, or it can be supplemental to it. They say 4 milligrams twice a day. BID is twice a day. Again, I take the 2 milligram tablets. You can always take 2 of those. They're very tiny. It's hard to break a 4 milligram 1.5. And I think sometimes it's fine to start with a low dose. You can always give yourself more. It's hard to give yourself less once you've taken it. Remember, what do steroids do to your blood glucose? Raise your blood glucose. So somebody who has a history of diabetes or brittle diabetic, you got to be careful with steroid use. Elevated blood sugars are also going to give you an osmotic diuresis. So again, keeping up with your fluids is very important. Ibuprofen, we talked about. There was a study that did a comparative study, inhaled budesonide, which is an inhaled steroid, versus oral dexamethasone to prevent acute mountain sickness. And basically the conclusion was they both work. I think it's easier to carry a little thing of tablets as compared to a inhaled budesonide metered dose inhaler. In summary, very much like seasickness, you feel terrible, feels like a hangover. Both of them are your body's in a new environment. They both adjust over time, generally self-limited, rarely life-threatening, even though you may feel like you want to die. Unless you have HACE or HAPE, you're probably going to do fine just with some minor treatment. So this was a case of a 30-year-old female. She was hiking at 10,000 feet in Colorado with severe headache, insomnia, anorexia, nausea. Her SpO2 by pulse oximetry was 89%. Remember, we said 90 to 92 is the lower limits of normal. Lungs are clear, so she doesn't have HAPE, right? Neuroexam is normal, so she doesn't have HACE. You diagnose acute mountain sickness. What would you recommend for this gal at 10,000 feet? So what would you treat her with? Treat her symptoms, right? Probably give her some ibuprofen, plenty of fluids. If you could, you give her a little bit of oxygen. Maybe you go down from 10,000 feet. You hate to ruin somebody's vacation and have them be sick. So if you can be wise about this, you hate to ruin your own vacation. So if you can be wise about this and avoid this stuff from happening, that's ideal. These are some of the things that can also be in the differential diagnosis: dehydration, exhaustion, hypothermia, hangover, carbon monoxide. Oh, that's a good one. Carbon monoxide. Always got to remember that. Sometimes when you're on these expeditions or excursions, they might have like a heat element. They may have a little propane something or a little stove, or they're cooking inside a close thing. Always consider carbon monoxide poisoning. Carbon monoxide, very similar to this. Gives you shortness of breath, gives you headache, gives you fatigue, gives you maybe an altered mental status. Gets more severe, you can actually have a seizure. So again, having in your medical kit the things we talked about. If you're going to be really going to altitude, you should probably have. You can buy, if you're out in Breckenridge, Colorado, you can go into these like oxygen bars and get a brief oxygen therapy if you have a bad headache. Probably works for a hangover too. That was that hyperbaric tank we were talking about. You basically put somebody in, you insulate it with high flow oxygen, and you create basically a sea level condition inside there. Put them in there for a couple hours. Symptoms are going to improve. You're going to give them ibuprofen, Diamox, some steroids. And you can also use this as a sled to get them down the mountain too. So what did that one person have? If we ignored those symptoms, the one that had the acute mountain sickness, we keep going to altitude. They go up to 2,500 or 12,500. They get ataxia and confusion. Now they have high altitude cerebral edema. And again, that's a much more serious condition. That person, you want to get down from altitude, either use hyperbarics or go down from altitude, give them a good hefty dose of steroids, oxygen, so that answers all the above. That's essentially any kind of cerebral edema. Remember, your skull is the closed space. Any swelling of the brain is going to cause pain, discomfort. The brain itself doesn't have pain fibers, but the dura around it does. Similar case, training for last 4 weeks in preparation. Day 3, he gets a little mild AMS, rest for a day, feels better. He lost a couple of days on his trip, so he busts his hump, gets up even faster. On day 5, he goes up 2,000 meters. That's a 6,000 foot gain. That night, confusion, mild ataxia, shortness of breath, cough. He's got HACE and HAPE. He needs to get down quickly. That's his x-ray. Remember we said rails predominantly in the right axillary area. That's an x-ray of somebody with high altitude pulmonary edema, more notable on the patient's right lung. Pink or blood tinged sputum, that's a late finding. A basin, Arapahoe Basin, is in Colorado, right on the Continental Divide. The top is somewhere around 13,000 feet. Children are at a greater risk for this. Even though we said age wasn't a big thing, children are at risk. This little lovely girl, here's my granddaughter. She was probably about 5 at this age. My son took her out to A Basin. We got this, I think we were there with her. Yeah, got this picture. She did really, really well because she's a maniac and a good skier at the age of 5. Now she's 6, going to be 7. Still loves to ski. But children with risk factors like cardiac defects, cystic fibrosis, cardiomyopathy, et cetera, they're at greater risk at altitude. Other things you need to consider, just because somebody's got pulmonary edema symptoms at altitude doesn't mean they didn't develop a pneumonia, doesn't mean they're not having an asthma attack. So again, physical examination, history is very important. We talked about treatment. Prevention is your best treatment. take-home message, prevalence is low. Pathophysiology, you want to get them down to normal pressure as fast as you can. Weakness, decrease in exercise performance. You want to treat them with oxygen. Nifedipine, sildenafil don't particularly work great, but you might have those in severe cases. You might try and throw the whole kitchen sink at them. So these are the things you want to have in your medical kit: Diamox, Dexamethasone, Zofran, ibuprofen, salbuterol, salmeterol. They're just basically pulmonary dilators. Tylenol, good to have, and a pocket pulse oximeter. We talked about dry eye, have a lubricating. Sunscreen is really, really important at altitude. The air is thinner, you're much more likely to get burnt, so you want to have at least an SPF 50. Polarized eyewear, you don't want to get a retinal burn. Retinal, I don't know if anybody's ever had retinal burn. It's similar to what arc welders get if they're not using proper protective. So if you're out in the sun all day, remember the sun is reflecting off the snow around you. You can get it's almost like a severe corneal abrasion, and you can get, it feels like you have gravel in your eyes. It's extremely uncomfortable. So polarized eyewear is really important. Lots of water. Anytime you're on an expedition, you should have an EpiPen, or if somebody has a known history, they should have their EpiPen with them. We talked about the antihistamines. You should always have those in your kit. Imodium or loperamide for diarrhea. Antibiotic of choice, I usually recommend the Z-Pak and doxycycline. Electrolyte replacements, aspirin, all this stuff if you're going to be doing on any extended trekking episode. Embedded in this video that's available through your school website are a bunch of links for different things that you can do. All right, any questions? This is in Yellowstone Park in the wintertime on a snowmobile trip. Beautiful, you ever get a chance to do that. We weren't at much altitude, but it was a good trip. So again, in summary, we went over a lot today. Acute mountain sickness, hard to avoid. Be smart about it. Have a good kit in case you get sick that you can prevent some of the symptoms. If anybody you're with starts to have pulmonary edema symptoms or confusion, ataxia, they need to go down to lower levels. And if you ever have that question, what's the percentage of oxygen at altitude? It's still 21%. Okay? All right. Hope one or two of these things may be useful to you in your personal life and future trips. Have a good afternoon.